So today the focus will be on magnification and the routine of prescribing magnification. So low vision patients struggle with poor vision, even with the optimal refractive correction. So even with the best corrected vision, they still struggle to be able to see things. So the point of magnification is not about making the objects clearer. It's simply about making them appear bigger so that the patients can see it. So this is just a bit of text to make the point. So this is, you've just got regular text here that hasn't been magnified. And this is how we would see it as normal without any problems. However, the same text, if the patient has a scotoma, that is what they would see. So the majority of the text would be covered by that, and they'd only be able to see small segments or small parts of it. Now, if we take the text and we magnify it, and it's the same level of scotoma, the patient is now able to see a lot more of the text. So it's not that the text is clearer, but we basically just magnified it and made it bigger so that it's easier for the patients to see it, and they're missing less of it, basically, depending on the cause of the visual impairment, of course. So this image shows the retinal perspective of that previous slide, basically, showing that by magnifying the text, you see that more of the text falls onto the healthier retina and less of it on the geographic atrophy of the AMD case in this case, basically. So magnification is relative. So it is the ratio of comparing the situation before versus after some change in the viewing environment has occurred. So if a patient can't resolve the retinal image, despite it being optimally focused, then it must be enlarged so that they're able to see it. So to work out magnification, you divide the new retinal image size by the old retinal image size. And there's 4 different ways of magnifying things to make it easy for the patient. So the first one being relative size magnification, the second one being relative distance magnification, and then we have angular magnification and real image magnification. So in this little illustration, it basically just shows that when you have an object and you're looking through, it's that purple area that they are able to see, or that's the retinal size of it. So looking at relative size magnification, this is concerned with making the object bigger. So for example, getting a bigger TV screen, or using a larger print book, or increasing the font size on the PowerPoint presentation, or guiding the patient to use a tablet instead of a smartphone, which is something that's more sort of easier to do nowadays with the advancement in technology. However, these can be limited by practicalities of physical limits, of course. So there's a linear relationship between the object size and the retinal image size. So as you can see, as the object size increases, the retinal image size also increases, as illustrated in the diagram. So relative size magnification. The magnification is calculated in comparison to a standard or reference or initial size, as we said earlier. So that's the situation before and then after. And the advantages of the size magnification is that no change in the habitual posture is required. Little or no training is also required. And the patient can easily arrange this for themselves, and they don't have to wait for a healthcare professional to arrange it for them. So they can basically just go out and buy a bigger TV, or just buy or order a book in a larger print, etc. However, the disadvantages of it is that the original becomes larger or heavier, and therefore it can be a bit more difficult to carry or to use it. And it also limits the magnification. So there's only so much you can increase the size of something, or it becomes, before it starts to become less practical. And then also bear in mind that enlarging by photocopying can also reduce the contrast. So this picture shows that you've got the same book, but the book on the left-hand side hand side has the larger print on it, whereas on the right hand side, it just has the regular print size on it or font size on there. So moving on to relative distance magnification, this is the simplest way to basically increase magnification, and it's to reduce the viewing distance. So if you have a patient who's watching TV at 3 meters and they move closer to it, or the TV is brought in nearer to them, and they're only about 2 meters away, that gives them 1.5 times the magnification now. And then if you move a reading task from 40 centimeters, to about 50 centimeters, this will give you 8 times that magnification. However, it's a little bit different when we're talking about near vision, because then the accommodative demand is also affected or impacted. So the question is, what happens to the accommodative demand? So increasing from 40 centimeters, which is about 2.5 diopters, to about 5 centimeters increases the accommodative demand to about 20 diopters. So with the accommodative demand, it changes when you bring the object closer, but you can remedy this by using a convex lens. So if you bring in the object closer, by using a convex lens, you have parallel rays of light emerging. So magnification with a positive lens. To assign a magnification, it must be compared to a standard, as we said. So by convention, this is compared to a 4 diopter lens or 25 centimeter working distance. So to work out the magnification, you would do the power of the magnifying lens divided by 4, and that would give you the required magnification. So if you had a 12 diopter magnifier lens, that would give you 3 times the magnification. And then the third method was the angular magnification. So this generally refers to the magnification provided by optical instruments such as telescopes. And it is actually a versatile mean of magnification, as it doesn't involve changing the object or viewing distance. And the way that you work it out for angular magnification, that's the angle subtended at the eye by the instrument divided by the angle subtended at the eye by the object. And there you have the telescope in between the object and the eye. And then the fourth method, which is real image magnification. So this is basically where you use CCTV. And no, I don't mean that kind of CCTV, this kind of CCTV. So CCTV stands for closed circuit television device, where you basically just enlarges anything that you put underneath it, and it projects it, all the images created on a TV screen. So you can also combine, so that's the 4 main types of magnification that we talked about, but you can actually combine different magnifications with one another, and use them alongside one another. So the total magnification, if you were to do that, would be the product of the 2 values. So for example, to work out the total magnification, if you were to use a larger object, but also move closer to it, would be the relative size magnification times the relative distance magnification. So in terms of prescribing magnification, how do you know how much magnification is needed? So the typical routine when prescribing low vision aids is to, number 1, identify the specific tasks that the patient is sort of requiring the magnification for. What are they wanting to do? Are they wanting to be able to read instructions for cooking, or read cans for ingredients for cooking, etc.? And then also think about binocular or monocular correction and which one's preferred. You then look at selecting the appropriate low vision aid, and then perform a trial for suitability as well. And also don't forget to determine any spectacle correction that might be necessary as well. And then after some training, you would loan this out to the patient, and arrange follow-up visits for them to see how they're getting on with it, and then obviously adjust things if as required. So predicting the distance magnification. So this is comparing what the patient can already see to what the patient wants to be able to see. So typically, if someone's watching TV, you're looking at around 612 is required. But if they're wanting to be able to read bus numbers, that would probably be about 66. So you do the required VA over the actual VA or the current VA, and that gives you the magnification. And then predicting the near magnification. So for example, if you have a patient with distance spectacles of -1 diopters in both eyes and reading spectacles of +4, and with their reading specs, they can see N13, but they want to be able to read the newspaper and know when they're free to socialize again and we're off lockdown. And the newspaper print is around N8, then they would need 4 times that, but that's only reading at threshold level. If they wanted to be able to read things fluently, you'd do 3 times that for reserves so that it's easier and they're not straining their eyes and they're not getting headaches because they're reading at threshold level. So thinking about binocular and monocular magnification. So if the visual acuity between the 2 eyes is similar, then binocular viewing is beneficial to the patient. However, if the design of the magnifier is limited, then you probably look at monocular correction then. And remember to also reassure the patient that using just 1 eye isn't going to make their condition worse. So they can still use just 1 or monocular magnification instead of binocular if that's more suitable for the task that they require it for. And then selecting the low vision aid. So once the value of the magnification required has been predicted, you then basically need to find the best way or the best method or low vision aid that would be able to allow the patient to have that level of magnification that is required. And you've got 4 options as well, which is, again, making the object bigger or decreasing the working distance or increasing the angular magnification using a telescope or the real image magnification. So the distance magnification, the main sort of practically useful aid is the telescope. And then in some cases, you might be able to move the object closer. So either you move closer to the TV or bring the TV in a bit nearer. And then for near magnification, your common ones are spectacle microscopes, handheld magnifiers, or stand magnifiers. And of course, the object can be made a bit larger, but that's typically restricted to a magnification of about 2 times. Real image magnification is also possible with CCTV for near. And then you also have telescopes for near as well, which are helpful if the patient wants to perform manipulative tasks. So after calculating the magnification required for the patient's visual needs and the working out of what type of LVA is most suitable for the task, you trial it and test it out, same as you would with a contact lens trial, and then book them in again for another appointment to see how they're getting on. So and then with regards to this spectacle correction required, distance telescopes can be used alongside the distance prescription. However, the largest field of view is obtained when the exit pupil of the telescope is as close as possible to the entrance pupil of the eye. So if you are using the telescope alongside the distance RX, it does reduce, it increases that distance a little bit. And for near vision, obviously the general rule is that if you're using a handheld magnifier, you use your distance prescription with that. And then for a stand magnifier, you would use the reading prescription for that. And then you train them and teach them how to use that. That's important to improve the chance of success with the low vision aid. and the patient should be able to keep the magnifier clean, and you'd inform them of that. And some magnifiers will probably require little training, such as hand magnifiers, whereas others, such as CCTVs, especially if they're elderly, will probably require a bit more training as well. So this table shows the different types of magnification and how they vary with regards to the field of view, the effect on working space, and the distance at which the type of magnifier is used for. So by increasing the size, that doesn't really change the field of view, but it tends to be more used for near, such as like getting a larger print book, and then decreasing the distance doesn't affect the field of view as such, and that can be used for distance, intermediate, or near. And then real image, which is the CCTV, we said was only practical for near vision or near tasks. And then the angular or magnification or telescopes can be used for distance, intermediate, or near. However, that greatly decreases your field of view. You've got much smaller area to be able to see through it. So you have to scan what it is that you're doing. And that brings us to the end of our talk today, actually. So just to recap, so we talked about the magnification and the 4 different ways to magnify an object, and their advantages and disadvantages. So I think if you were to take one thing away from this talk, is to use the patient's actual VA and the desired VA to predict the required magnification, and then you'd probably be able to figure out the rest after that. And then with regards to the routine of prescribing the magnification, it's important that you have a good understanding of the patient's visual needs in order to be able to prescribe the most suitable low vision aid or magnification to them, basically.